All right, everybody, welcome back to the Dr. Doug Show. I am excited for this interview that I have for you today. So today I interviewed Dr. Carrie Jones. I'm just going to actually read you her bio, which I don't usually do, but there's so much stuff in here. I want to make sure I hit it all. So Dr. Carrie Jones is an internationally recognized speaker, consultant, and educator on the topic of women's health and hormones with over 20 years in the industry. Dubbed the Queen of Hormones, Dr. Jones is a naturopathic physician who did her 2-year residency focused on women's health and endocrinology. She went on to get her Master of Public Health, was one of the first to become the board certified through the American Board of Naturopathic Endocrinology, and is a Menopause Society certified practitioner. She was the first medical director for Precision Analytic, who makes the Dutch test, and the first head of medical education at Rupa Health. She co-hosts the highly popular show, the Root Cause Medicine podcast, that has over 10 million downloads. She is the clinical expert for the Lifestyle Metrics Resource Center. She was on Under Armour's Human Performance Council and is an advisor for Menopause. Currently, she's the Chief Medical Officer at New Ethics Formulations and the Head of Medical Education at Metabolic Mentor University. Wow. So, obviously, Dr. Carrie Jones is, I'm just going to call it, she's the bomb in the hormone space. And I've heard her delivering education. She actually created content that helped me to learn how to use supplements around estrogen metabolites. And that's what we talk about today. So we get into estrogen metabolites, the Dutch test, why somebody might want to use it, what are the things they could potentially be treating by using it. And we walk through some of the debate, some of the controversy of a lot of doctors who are saying that the Dutch test is something that shouldn't be used and that any doctor who's using it is performing malpractice. And we hear really, really strong verbiage like that. So this is a great interview with Dr. Carrie Jones. She's always fun to speak to and to chat with. We've done a couple of different interviews now. First time I've had her on the podcast and on the Dr. Doug Show. So I hope you enjoy. Dr. Carrie Jones, so good to finally have you on the Dr. Doug Show. We have some super fun stuff to talk about. Thank you for joining us.
Oh, as usual, I love talking with you about all things hormones and bones, so this is going to be fun.
Awesome. Great. Well, let's just get right into it because I think a lot of our viewers and listeners probably are familiar with your work, but some of them might not be. So can you just give us like the kind of short summary background of sort of who you are and how you got here into this space?
I am a naturopathic physician. I have been a naturopathic physician since 2005, so a very long time, and I've been in hormones and women's health since the dawn of day. Once I realized I honestly didn't know what was going on with my body, and nobody really else seemed to know what's going on with their body, I just stuck with hormones for that reason. I had a private practice for close to 15 years, saw a lot of patients, and then I was the medical director for a hormone test called the Dutch test for almost a decade, and have a lot of experience in labs as a result. So my whole love and passion and goal are women's health, hormones, and how frustrating it is that we just don't know that much about ourselves.
Yeah, well, that seems to be true. So I was first introduced to your work by trying to learn about urine metabolites and estrogen metabolism and trying to sort this out for myself because when I was learning about estrogen, I, like everybody else, of course, was taught that estrogen is dangerous. And then when you start reading the literature, you realize, like, that's probably not true. But then what about all of this signal here? What about this concern about this metabolite? And it gets very complex very quickly. What I loved about the work that you did at Dutch is that you guys produced so much content that helped to explain what we're looking at, what the tests show, what the metabolites are, what the phases of detox are. So it was really helpful for someone like myself coming into this late, getting a grasp of like, what are these things? So my goal today is I want to kind of walk through some of this, but from the consumer's perspective, because I know we get questions all the time. People they're on Instagram, they're listening to other menopause experts, hormone experts, and they've been told like urine metabolites are crazy, like nobody should do them, we don't need them, just do blood tests, never do urine. And so there's so much confusion here. So I want to sort of break this down for people. I think let's just start with like, when I say estrogen metabolism, like what does that even mean?
Estrogen metabolism, estrogen metabolites are basically what's called the breakdown product of estrogen. So from an analogy point of view, picture a puzzle, a fully completed puzzle, and now we've named the puzzle estradiol. So the puzzle is beautiful, you can show it to people, it's one whole thing. Now you need to put the puzzle back in the box. So you break it into a whole lot of pieces. Those are estrogen's metabolites. They're the breakdown product of it. But imagine each of those puzzle pieces could be active. They can bind to receptors, they can do things maybe good, maybe bad. So when we think of metabolism, we want to direct those puzzle pieces to go, again, towards the better way, the healthier way, the less reactive way. I don't want puzzle pieces that are going to cause maybe growth or cause heavy periods or cause PMS. And so by understanding that we can use diet, lifestyle, supplementation, nutrition to modify our puzzle pieces, then it puts all the power back in women's hands on controlling what their body's doing.
Yeah. So then let's dig in a little bit on, like, if someone has, let's say the metabolism is messed up in some way and they have one of these metabolites that's potentially not favorable, like, what are the things that we're worried about there? Like, why does this matter?
It's a spectrum. So the worst case scenario, of course, is that research has shown that some of these metabolites can cause breast cancer to grow. It doesn't necessarily mean it's the trigger for breast cancer, but if you have it and things are replicating, it's going to perpetuate the replication. Now, on the other end of the spectrum, it's more like annoying estrogenic symptoms, breast tenderness, heavy periods, fibroid growth, polyp growth, and worse, endometriosis pain. So we can kind of get in this spectrum depending which of the metabolites is sort of favored in the body.
Yeah. So do we want to walk down what those metabolites are? Because I think they're common. The names are probably common enough that people have heard of them. So without getting too techie here, what are these metabolites?
So we have let me back up. There's 3 phases of metabolism. And oftentimes we just call it detoxification. So when we're looking at these 3 phases, the first phase of metabolites you can go down have 3 options. So we can go down what's called the 2 pathway, and it's 2-hydroxy, because of course it has to be scientific, 4-hydroxy, and 16-hydroxy. I don't know why they're not named 1, 2, 3. I'm not the scientist behind it, but it is 2, it is 4, and it is 16. The 2 pathway is the better pathway. It's the green pathway. It's the less reactive pathway. That's the pathway we prefer. The 4 pathway is the more reactive. It's the more carcinogenic. So we don't have a choice that we can never turn that off completely, but we do want to minimize that pathway as much as possible. And then the 16 pathway is kind of a gray area pathway. Interestingly enough, it's good for bones.
Right.
It helps because it's estrogenic. It could help bones grow. But if you have breast cancer or polyps or fibroids, it might help those grow too. So it's a grower. And so we want that in the gray area. It's like a balance. It's Goldilocks. So those are your phase 1 metabolites. Then they move through to phase 2 and form different metabolites. Those are all actually so much better for you. So the most famous, I would say, phase 2 metabolite is called a 2-methoxy, which is actually shown in research to be really protective for you, really healthy for you. So you want your hydroxys in phase 1 to move to methoxys in phase 2 very quickly. They keep moving. They can add a little S or a little G on them, and then they go through what's called sulfation or glucuronidation. And the whole point in you're moving through this process is to make them water soluble so that you can get rid of it. You can either urinate it out or you can eliminate it in your stool. Yeah. So hormones just by default aren't able to easily move through the kidneys or move through the intestines. So it's a multi-step process to make them less and less reactive and in some cases really healthy for you, and then get rid of them.
Yeah. Yeah. So then this is where people, I think, get really excited. They're like, oh, well, I want like this one and not this one. And then it's, like we look at the test, and I want to talk about what the test shows, but we look at the test and you can see these pathways, but there is a lot of evidence suggesting that there are interventions that can help us to do this to some extent. We can't just like pick 1, 2, and 3. Like, it doesn't work like that, but we can make a difference, right? Like, it is possible to impact this metabolism.
And here's a great example. So genetically, we are prone often one pathway or another. So if you have done your genetics, you can actually look at the enzymes that go down these pathways. So in the first set of that phase 1, they're called a CYP. So anyone who's done your genetics, look for your CYPs. That's a phase 1 detoxification mover. So CYP1B1 goes down the red pathway, the naughty pathway, the carcinogenic pathway. We don't like that pathway. Genetically, mine is upregulated, which means by default, I should move down that pathway. However, when I do testing, I do not. I go down the other pathway, which means enough of my lifestyle and interventions and supplements are moving against my genetics, thank goodness, and keeping me on the better pathway. And just giving my own example, I love to show that for women of like, yes, you can modulate this. You're not stuck with this forever.
Nice. Yeah. No, that's great. And do you do genetics? Do you have a clinical practice now? Are you still doing clinical
I
work?
do not have, not
Yeah.
at the moment,
I didn't
no.
think so. Yeah.
No. But
So I
I've
was
done
like-
a lot of genetic tests.
yeah, I would say when you were practicing, was genetics a big part of what you were doing in addition to the urine metabolites?
It depended on the person, quite
Uh-huh.
honestly, like what we were trying to accomplish, and honestly, budget. You know, as much as I love genetic testing, and it is
Yeah.
a one-time test, you just need to do it once, and because your genetics inherently don't change, we can modulate them, but
Right.
what you have in your body, you know, you're born with. However, it didn't fit for every person, but I would love to. I think knowing it's like a roadmap, a guideline. Even though your genetics may not express, and there's a lot we can do to change them. Sometimes just knowing what I'm up against ahead of time. Like for me, a lot of my estrogen genetics, my SNPs, are not great. And so I learned really early on that I needed to be proactive about this.
Yeah. So let's say somebody knows that, or let's just say that their Dutch test shows that they have
Yeah.
metabolites they don't want. Let's get into like, what can we do? Like, what are some of the tools and how do we apply them? Of course, recognizing that we're not telling anybody what to do specifically because we
Right.
don't know what you're up against, what your genetics are, what your test shows. But just in general, with your experience, what have you seen to be effective for which specific things?
So generally, most of phase 1 detoxifications happen in the liver. So whatever you do to protect your liver, whether that's eliminating environmental chemicals, the estrogenic type chemicals, reducing your exposure, changing to healthier, greener products, that's a good thing. Reducing or eliminating alcohol completely or any kind of drugs, that's a good thing. Anything you can do to protect your liver is only going to improve your detoxification. Now, with this detoxification, your phase 1 liver enzymes use iron. So if you're iron deficient or you don't eat a lot of iron, you've been told you're iron anemic, you're just in general going to struggle with your phase 1. And so just some of these basic things can be really helpful for people right off the bat. Now, the next layer down is, well, how do I specifically maybe work to push the better pathway, push that greener 2 pathway? Well, firstly, diet. A big part of what's called the brassica family, the broccoli, the kale, your cauliflower, your broccoli sprouts help push down that pathway. So if you don't eat a lot of broccoli, if you're not eating a lot of cauliflower, Brussels sprouts make you gag, maybe it's time to figure out a different way to cook those and get them in your diet because they can be really helpful. When you eat those foods, they have an ingredient in them called I3C, indole 3 carbonyl. And when that molecule hits your stomach acid, so you swallow the broccoli, hit your stomach acid, it breaks apart, and one of the most active ingredients is called DIM, diindole methane. And people have probably heard of DIM supplements.
Yeah.
DIM helps modulate down the 2 pathway. It prefers the 2 pathway. So that's why food is medicine. Eating those foods or even this supplement can help push you down the 2 pathway. Now, let's say you're like me and you prefer the naughty little 4 pathway. So can we block it? We can't permanently block it, like we can't shut the road down, but we can minimize or redirect. And some of the helpful things are quercetin. And foods that have quercetin are like your apples and your onions, but there's even supplements for quercetin. Resveratrol. Resveratrol is a pretty potent antioxidant. It can be helpful at, again, like minimizing that pathway. And then I mentioned broccoli sprouts. In particular, broccoli sprouts, when you chew them or throw them in a smoothie, eat them, chop them up, they form something called sulforaphane. And sulforaphane helps kind of open all the doors, over 200 doors to detoxification. So if you have, it's like roads that are blocked or roads that are going the wrong direction when it comes to detox, it's like, no. Let's just open all the doors, get all the trash out, and make it easier. So again, food is medicine. Broccoli and broccoli sprouts, cauliflower, Brussels sprouts, apples, or even maybe you need to hit harder, and that's where the supplements can come into play in that phase 1 area.
Yeah. And so those supplements then would be I3C, DEM, sulforaphane. And how do people know which of these to use?
So this is where it gets tricky. So DIM, research is showing that DIM can reduce estrogen out of circulation. And it's just the phase 1. So if you have low estrogen, if you're listening to this and you're perimenopausal, postmenopausal, and you already have low estrogen, you probably don't want to use DIM or indole 3 carbonyl. You don't want to start with those products. You want to go the next layer down. You want to go to that methoxy layer that I mentioned. The methoxy layer loves magnesium. The methoxy layer actually loves sulforaphane, so broccoli sprouts. The methoxy layer loves choline. The methoxy layer loves methylated B vitamins, so methyl B12, methylfolate, methyl B6. It loves zinc. So that next layer down, and you can find a lot of these in foods as well, and you can get them in supplements. But that healthier next methoxy level also needs nutrients to make it happen, make it work better. So when I have somebody who's menopausal, postmenopausal, I don't do DIM. I go the next layer down, or I go the third layer down, which is how's your digestion? Do you have constipation? Do you have a daily bowel movement? Are you hydrated? How's your kidney health? Like, we have to get it out of the body. Estrogen is not sweated out of the body. A lot of people love their saunas. They love to sweat.
Yeah.
That's not how we detox estrogen. It comes out through the kidneys or out through the intestines. So how is the health of that?
Yeah, man, that's really helpful. Is there in the like phase 2, going to the methoxy side, are there different supplements for that, or are we just saying sulforaphane gets you down that pathway, doesn't reduce estradiol too much? What else is there?
Sulforaphane's a huge one as far as food-based goes, but you can obviously get it as a supplement. But then all the things that I mentioned, magnesium, zinc, choline, the methylated B vitamins.
Yeah.
The methoxy is called methoxy because it's part of the methylation cycle, and the methylation cycle in your body needs a lot of methyl B vitamins, and magnesium is a cofactor.
Right.
So definitely getting, we hear about magnesium a lot, and being involved in several hundred reactions, and the detoxification of estrogen is a big one. Yeah.
What's your favorite way, when you were clinically practicing, what was your favorite way to get people to have adequate magnesium?
Just supplement it. Just give it to them.
Yeah.
And I understand people are like, can I just get that in dark chocolate? I mean, there's some. Sure, I'm not going to take your dark chocolate away from you, but we do need to add in magnesium. And I'm a huge fan of, depending which direction we need to head with magnesium, a lot of people say, well, which one's the best? Well, they're all magnesium.
Yeah.
It's the second word is a bonus. So, for example, magnesium glycinate, the glycine helps with sleep, right? Magnesium citrate, highly absorbable, also helps if they have constipation. Malate, magnesium malate, helps the muscles. Orotate, helps the heart. So I have a couple different options depending on who the person is in front of me and what we're focused on.
What are your thoughts on mag oxide? It's always a common question for our team.
So that's so funny. I was just looking up mag oxide last night. So mag oxide has the reputation of, it has a lot of magnesium, but it's not very well absorbed. And then it can cause loose stools. Let's just put it at that. Yeah. But then I've read other research that mag oxide is not as bad as we thought. It's actually more absorbed than we thought it was, but still can cause loose stools.
Yeah.
And the loose stools, people don't really appreciate unless major constipation is their problem. So I don't use a lot of mag oxide at all. I lean towards the glycinate and the citrate. The citrate especially if constipation's an issue, but because nobody seems to be able to sleep anymore, myself included, then I lean towards the glycinate.
Yeah. Okay.
How about you? What do you think?
Yeah. So one of the products that we use frequently has mag oxide in it. And it's like one of the most common complaints that we get, and we have to be careful with loose stools because it does happen. It's not a lot of mag oxide, but it's enough that if you're sensitive to it, it'll provoke it. But we don't use that product to optimize people's magnesium levels. We use a mag glycinate or bisglycinate, citrate if they have more constipation. 3 and 8, people like 3 and 8, but you don't get very much mag out of mag 3 and 8 when you take it at night. So sometimes it's like 3 different mags, and that's what it takes. We use RBC mag, which isn't perfect, but it's better than serum mag. And we just, it's hard, for some people, it's hard to get levels adequate on RBC mag. And for people who don't know what I'm talking about, that's the red blood cell magnesium. So you're actually looking at the amount of magnesium in the red blood cells rather than just in the blood itself, because in the blood itself is very tightly regulated. So that test really means nothing unless you're really sick. So you need to use red blood cell magnesium. So then when we talk about, when I talk about this test, I've talked about this in some of my posts on social media, and I got some really strongly worded feedback. And so there are people out there who really think that and these are professional individuals, and I'm not going to name names because I don't like to throw people under the bus, but there are some very well-known and somewhat popular individuals who are talking bad about this type of testing on social media, writing posts, writing articles, whatever. And they're saying that any doctor that's using this type of test is, essentially practicing malpractice, and that they're just trying to make money, and that they shouldn't charge for this test, and this is ridiculous. What is your response to that? How do you deal with this kind of negative feedback, assuming you would probably get it too?
I do get it, yes. And having worked for the company, like I said, for almost a decade, I heard it all the time. And unfortunately, sometimes their argument is really unfounded. For example, they'll say that, well, there's no research behind it.
Yeah.
Like, well, that's interesting, because they have an entire page dedicated to research. And there are other companies and universities and places using the Dutch test as the hormone test of choice, because they're actually looking at the metabolites in their research. Now, research is expensive, and it's a slow roll to get published. So it's not like there's dozens of research articles behind the Dutch test, but they've been consistently working to get published over the last many years to show the, legitimacy of this test. The other thing is that I've noticed people will bash the Dutch test who've never actually even used it. Like they've never tried it, or maybe they bought it. They bought it to prove that they had to buy it, and it was a couple, $100, and that bothered them, and so they were mad. And I've seen that argument as well. They've never actually used it in their practice or themselves. They never got anyone to review their own results with them to tell them what's going on. And I find that curious. Why would you completely bash and put down a test you've never used, you've never been trained on?
Yeah.
And so it blows my mind sometimes on the feedback, because I'm like, wow, there's no research and you've never used it, but yet you're making this angry post and calling people, the doctors or any practitioner who uses it, malpractice.
Yeah.
I don't quite understand it. I don't generally have good conversations with them to understand it further. They don't come to me for help.
Yeah. No. Well,
and then I just go support the thousands of practitioners
that use it.
Including the many OBGYNs. I have a lot of OBGYN friends, because it's usually OBGYNs who bash it.
Right.
But I have a lot of OBGYNs who are like, this has revolutionized my practice.
Yeah.
I love this test. I've learned so much from this test. Now, there are caveats. Like any test, it is not the panacea of tests. It will not solve all problems for all people. But used in the appropriate setting, it can be wildly helpful.
Yeah, and so the people that are out there who are bashing it, I think, are also doctors who are in a traditional medical system. They will bash anything that is in what they would call the fringe of healthcare. But the truth is, to say that there's no research is insane, because there are a lot of studies. And again, Dutch does a great job. You did a great job of, like, these are the studies. This is what it shows. Here's the link, right? Like, go look at it yourself. So there are definitely studies, and then I've heard them also follow that with, where is the several thousand people trial that shows this, and that? And I'm like, that's a million or tens of millions of dollars study that no one will ever do. Yep. And so, you have to understand that, like, if we want to further healthcare and use some of these things that are going to help us to optimize our health, this is a cash pay system. No industry is ever going to bring this into Medicare, Medicaid. It's not going to be an option from my perspective.
Right.
I'm sure some people probably disagree with that. But I think it's always going to be in this sort of next level of healthcare, whatever we want to call that. And then
it's not in the guidelines. And I understand, the guidelines are serving the masses. They're serving hospital systems. They're serving insurance systems. Or a lot of guidelines are based even in other countries, right? In the UK, for example, the NHS, their guidelines are to serve the NHS, the Dutch test, or any functional test out there is not going to make its way into either government or insurance-backed system. It's unfortunately, we're just not in that world yet. And so that's okay.
Yeah.
I find the test wildly helpful. Like I said, it's been around for 12 plus years. Thousands of practitioners, lots of doctors love it.
Yeah, and I find too the response by some of the doctors that are in the system that would say that anytime a doctor is charging to interpret a test is, a waste of your money, or they shouldn't charge for that. They just don't understand what it means to live in a cash pay world. Like, we have to charge for our time, otherwise our practices wouldn't exist. And so they'll say, like, oh, well, this physician charged, or this practitioner charged, $600, and that means that it was like double the cost of the test. But if you've ever, you have, obviously, I have as well, it takes time to review these tests. It takes a lot of time to make very specific recommendations, to look at their genetics, to look at what they're doing. Like, it is time consuming to get into the weeds, but then to make these recommendations and come out with like the top 2 or 3 things that's going to help somebody. So like you have to charge for that. That's what you want from your physician, right?
And my primary care has me come back sometimes to go over things. You know,
Yeah.
they don't do it in the portal that, you know, my insurance system uses. And they don't call me. I'll get a message from the nurse that says your doctor would like you to come back in to discuss it. Well, guess what? I have to pay a copay and it gets charged to my insurance. So even in this system, I'm like, what do you mean?
Right.
You do it too sometimes if you have to give big news or explain something. It's not everything is free over the phone.
Yeah, I know. It's such a challenge. But, you know, we are doing the best we can in this space. And I think we are helping a lot of people. And clearly, you know, we still have the clinical practice, the bone health practice, and, you know, they can't get the care that they need in the traditional medical system. That's why we built what we built. So it is, you know, hopefully maybe someday I will be proven wrong and that, you know, all of this stuff will be wrapped into some kind of a provided for system. And that would be amazing. I just don't see how that's going to happen.
Not anytime soon, unfortunately. I actually just got a message on Instagram this morning from somebody who said she just saw her OBGYN, she's perimenopausal, and her OB said, because your cycles are regular, you have no hormone issues, and that was it. That was the end of their visit. And I thought, wow. And yet we're the problem, Dr. Doug. You and I are the problem, right?
Yeah.
We're the fringy ones.
We're
and this
fringe,
poor person's like, I'm now on the hunt for a new practitioner because what? I'm like, I know.
Well, yeah, and what do you tell them? So that I was telling you before we hit record that I was doing a talk last night, and one of my talks was on hormones, and that's what everybody asked. They're like, "How do we find a doctor who will talk to us about this?" And I was like, "I don't know what to tell you. I really don't."
It's a lot. What I tell people, I mean, they're obviously really good. You know, A4M is a find a practitioner. So American Academy of Anti-Aging Medicine, IFM, the Institute for Functional Medicine, and then there are very different groups. I'm a naturopathic doctor. So naturopathic.org has a find a practitioner.
I didn't know
They
that.
all can go by your zip code. But again, you have to do your due diligence because not everybody
Right.
agrees within that. You may not like their personality. You may not like their fit.
Yeah.
So what I tell people is ask your Facebook groups, ask your sister, ask your
Right.
friends,
Right.
ask your coworkers. Hey, do you like your doctor? Or your practitioner? Maybe it's your nurse practitioner, your PA, whoever it is. Like, do you like them? And who are they? Are they taking new patients?
Yeah.
Go that route. And I am all for. I do want to say this. I know there are a lot of online options now, especially in the hormone realm. You call or you do a Zoom visit, it's 10, 20 minutes, you get your hormones sent to you in the mail. So I am glad hormones are available in some of those quick systems, but it's missing sometimes the rest of the approach. Hormones are amazing, but
Yeah.
they're also not the foundation. And
Right.
we need the foundation. Both men and women need the foundation. And
Absolutely.
so that's not discussed. Like estrogen's not going to save you if you're drinking 2 to 3 glasses of wine a night. And estrogen's not going to save you if you just don't ever exercise or you're stressed out to the max.
Yeah.
So
Yeah,
we need it all.
And so we built one of those companies. So Pema Bioidentical.
I know, but you
is
still
our
do the
company.
foundations.
Well, but we have 2 companies. So we have Optimal Human Health, which is all bone health oriented for the most part, with some exceptions. And then we built a hormone company, but we intentionally built it actually without the coaching, because what we found is that there are a lot of people that are doing the foundation. There's so many good coaches out there.
Yep.
So our goal is to say, hey, if you are doing the foundation, you guys are working on the lifestyle stuff, and you just need someone to prescribe, that's what we want to provide for you.
Yeah.
Because building out, people that are doing the coaching also know that putting that into a company to scale is very difficult.
Yeah.
And so I don't know how to scale it as an entrepreneur. Maybe I'm just not smart enough. Like I can't figure out how to scale that. That's why our bone health practice is still as small as it is. But the hormone company, we could then latch on to all of these people who are doing the great lifestyle work and then just provide the thing that they're missing, which is the prescriptions, which can be done, like you said, efficiently, easily, sends it right to your house.
But if anyone follows you even for a second, that they know you routinely talk about the foundational stuff.
Oh, yeah.
Right? You routinely, like you're not out there just to give quick access to hormones and make a whole lot of money.
Well,
It's
and Yeah, no money has been made yet, just to be clear. But, but it's a good investment. But what we do too, though, is in those provider meetings, we will say, look, because we get a very comprehensive lab panel. Look, your lab show this, this, and this. You need to be working with somebody. And now we have a great list of coaches in different spaces, and we can say, hey, you should go work with this person because they're really good at this. I think you're really going to like their personality once we get to know them. So we're like definitely pushing people down that pathway. Whereas what I fear from some of the big like insurance covered, very quick telehealth thing, they talk to you very quickly or potentially not at all, which blows my mind. Then they send you a patch in the mail and you're done. Yeah. And that's going to miss the lifestyle picture altogether. And you're not going to feel better.
Or you may feel better initially because you're like all excited, you have your hormones, and then you're like, well, I still have these other symptoms. I'm still having these issues. I'm still like some things got better, but these things didn't. And that's what I'm starting to hear from women. It was like, I got my hormones, and now what? Like, oh.
Right. I just saw some posts like that today. Yeah. And so then our approach with this type of testing is that we don't do it out of the gate for everybody. We bring people in, we use serum testing, and then we, see how we do. We ask them their symptoms, they're filling out forms, we're getting great objective data, and then we say, hey, you might want to consider this because of X, Y, Z, and then go down that pathway. I think everybody would probably benefit from it, but like you said earlier, it becomes a cost issue, right? Like it is relatively expensive. Not everybody wants to go down that pathway. If they feel great, they're doing great. We don't necessarily need to. I would love to do it for everyone, but it just, not everybody wants to do it, and that's okay.
Yeah, absolutely. And it's this even timing, right? Like the Dutch test, just as you said, as much as I love the Dutch test, a lot of caveats, and I don't use it for every woman. A perimenopausal woman who's in the throes of the chaos of cycles every 2 weeks, every 2 months. Yeah. I don't know. I'm like, oh, don't spend your money on that. Like, let's look at other things. Let's support you other ways right now.
Yeah.
You don't need it for that.
Did you use a cycle map much in your practice?
The cycle map is probably one of my top favorite tests for a woman who truly has a regular cycle. And I was very picky on when I used the cycle map. I didn't use it for irregular cycles. I didn't use it for the mid-late perimenopausal woman. I use it specifically when somebody says the fertility was a great option. I would use it for my fertility patients who had regular cycles and they've been trying things and it wasn't working. I had used it for women who had very clear hormonal issues throughout the cycle. Carrie, I get migraines right before ovulation, right after ovulation, on days 20, 21, 22, and 28. I'm like, whoa, let's do the month-long test. Let's check this out. And so I was very picky when I used it. But man, when you can see the whole month drawn out in a graph, I'm like, oh, I have my answer. Here's what's going on. Yeah. Or women with recurrent pregnancy loss. So they kept getting their blood tests on day 19, day 20. Their progesterone looked great. And then they would unfortunately lose around week 10, week 11. And what I would do on the cycle map, I would see them spike way up and crash way down. And because it can take a minute to get into their OBGYN, nobody was following up with them on their progesterone or putting them on progesterone. And it was really unfortunate. And I had several of those cases. And so that's when we would go back, do a cycle map. I'm like, oh, you have a progesterone ongoing production problem. You can make it, but it crashes as soon as you make it. Let's figure that out or get you on progesterone and then have you go see your OB once you're pregnant and they can maintain it. Yeah.
Wow. So that's great work. That's not the work I do. So yeah, we use it occasionally for similar reasons, but not the infertility part. And it's an amazing test. And for those people who wonder what the heck we're talking about, so the Dutch test is a urine metabolite test, and you literally pee on a strip. It's a very special strip, and you send it to the lab, and they get all the data off of it. It has been validated. I meant to say that earlier. So people say, well, you have to use serum. That's a gold standard. That's true. However, the Dutch test has been validated to serum, and it is, whatever the criteria were for accuracy and whatever. So it is a validated test. We know what we're looking at on the test. So, but it's usually a 1-day test. The cycle map is how many days during the month? Do you remember off the top of your head?
You collect almost every day. Yeah. And then they report 9 points on a map, on a graph.
Yeah. Do you have any idea, like just ballpark, how many strips that is?
I think it's 24 strips that you do. So you don't collect during your period. Yeah. And then depending on the length of your cycle, it's 20 to 24 strips, somewhere in there.
Yeah, it's a lot It's a lot of
Yeah.
peeing on strips.
But
But
it's only one every morning, so but it is a lot of strips.
but it's really great information. So yeah, we
Yeah.
use it occasionally, and every time we use it, we're like, wow, it's a lot of work for the
And
person doing it.
there are the companies now that have the at home option. There's the Mira and the Uva and the Anito and what have you. And I had one of those companies sent to me because they were like, we want to see what you think because I use so much experience lab. And again, I get it. I'm in my 40s, but at the same time, I'm still fairly regular. So I was using this test, and I would be on, I don't know, day 4 or 5 of my cycle, and my progesterone would be through the roof. So I would email my rep and I would say, I'm not on progesterone.
Yeah, how's this possible?
I'm on date. Yeah, how is this possible? They're like, ooh, technical glitch. Yeah, sometimes that happens. Like, don't pay attention to that. I'm like, what?
That's a big deal.
So I know it helps a lot of women. I don't mean to bash these companies at all. I do think there's more to go. And because I work with so many practitioners who are trying them themselves, we all kind of have that like, ooh, great idea. Can't wait to see how the versions play out and get better in technology. But we've all had those like, oops, technical issues where we're like, I don't know how to explain that.
Oh, yeah, that's why I think most people, like, I love being sort of a self-experimenter in this space.
Yeah.
Because I think it takes that mindset to be like, oh, this is kind of a cool thing. Like, let's try this out. And then like I try it out. My wife makes so much fun of me because I have all these gadgets and like stuff for sleep. And she's like, what is this thing? I'm like, oh, I learned,
Boxes show up in your mail and you have to, my husband's like, stop shopping. I'm like, no, this is from this company. This was sent to me.
Yeah, it is.
I didn't buy this.
Yeah, it's fun though because you see all this great tech and the companies have figured out the the influencer thing and it is effective marketing.
Yeah.
But I think we have to test it and really be comfortable with it. And I would say probably 9 out of 10 things that I'm sent I don't recommend.
I say, there's a lot of things where I'm like, nope. And I see a lot of hype on things for social media. Obvious't they're good for them. Some of these companies are paying large amounts of money, and I'm like, really, I didn't get that. Like, I didn't notice that. That's not the response I got. In fact, I gave mine away. Like, oops.
Yeah, I have some of those things too. I'm like, here, I didn't like this, but you can try it.
Yeah, exactly. Yeah, I'll have a friend that's like, hey, do you have such and such? Can I try that? I'm like, yeah, I didn't like it. Here, you can have it. Maybe it'll work on you.
Yeah, well, everybody's different.
We try.
So, all right, I think we've chatted for over 30 minutes. I think we should be done. Any last comments about estrogen metabolism? Anything that you want to leave the audience with?
Yes, I do want to say this. If you have done a test like this, or maybe you've read social media, or you have your genetics, please don't freak out. Don't think you can't do hormones just because of that. I have had women say, oh no, I got my genetics and my estrogen genetics look bad. I can never take estrogen. I disagree with that. I feel like it's very modifiable. We can modulate it a lot with diet, lifestyle, supplementation, nutrients, etc. that you totally can take estrogen. If that's the only reason holding you up, don't let it. We can absolutely work around that.
Yeah, no, that's a great takeaway. And I know you're not in clinical practice now, but if people want to find you, learn more about you, where do they go?
They go to my website, drcarriejones.com. I am also on Instagram at dr.carriejones and YouTube at Dr. Carrie Jones.
Beautiful. All right. Well, thank you so much, Dr. Carrie Jones.
Thank you.
All right. I hope you enjoyed that interview with Dr. Carrie Jones. If you are still looking for the right community to help optimize your bone health and you are trying to find information, you need a little bit more support, strongly encourage you to check out the Osteo Collective. The Osteo Collective is our community of individuals who are DIYing their bone health with help from us in the form of content, in the form of weekly topic-driven Q&As, the community so they can ask each other questions, the ability to purchase labs, so many valuable things within this community. Again, it's called the Osteo Collective. Link for that in the description on YouTube, or you can check out osteocollective.com and learn more information there.